And I get to throw in my 2 cents for Dr. Plancher because Dr. Plancher is also the chairman of the development committee for Anna, and he's one of the most impressive speakers. He actually also runs the Orthopedic Summit in the United States. So, Kevin.
Thank you, Mark. Good evening to all of you. Thanks to the kindness of your president, we're going to change topics for a minute because I have to be in New York on Friday, and we're going to, I hope, convince you today about partial knee replacements as a sports medicine physician or as an arthroplasty person. So we know that arthritis is present here, and you can see radiographic evidence in more than 40% of people over 60 years of age. But did you know that the arthritis that you see is often one compartment? And here in the Middle East, with the varus knee, I want you to think about holding off and not doing, and here's the crossfire, I win already for the Friday debate, that you don't do a total knee replacement, but you consider a partial knee replacement because of the preponderance of partial problems in the medial compartment and making people be able to do to prayer, to activities of daily living, and returning to sport without any problem. Why? Because I can preserve the cruciate ligaments, I can get you near normal kinematics, I can do it to improve your range of motion every time, and for us in the United States, it's less cost, and we actually do it as an outpatient. We don't do it any longer as an inpatient, and you'll see that. This is the proof. Look at all of these different x-rays. Arthritis in the knee is different for everyone. Some people have alignment problems. Some people have a full thickness cartilage loss, and you say, what's wrong with that? Well, they're grade 4 and they have pain. Other people are bone on the medial compartment, and other people have a slope problem. We need to look critically, and I'm here to tell you which patients you'll have success. The problem was, my mentors, even Dr. Scott, he's brilliant, said, you better not do this unless they're over than 60. You better do it if they're only skinny. You better do it if they have an intact anterior cruciate ligament. You can't be heavy set. You can't have a patella that has arthritis. And that's not right. We've changed that. In fact, we now know that as long as you can define the one compartment with arthritis, you can do people with varus or valgus up to 10 to 12 degrees. You can do someone that's missing an ACL, and you can ignore the arthritis in the lateral facet of the patella. So let me show you the science so you don't have to believe me. How about number one, concerns? If you're less than 60 years of age, you're worried that it's going to wear out, mechanical loosening, and up to 40%, as it says in the old literature, of revisions. I tell you today, 2020, this is science, 72 patients by someone else, less than 60 years of age, had 93% 10-year survival rate. Review of 6,000 knees, revision rate was low. How about if you're older than 60 years of age? The concerns were there that greater than 60 years of age, it wouldn't do as well. No increased risk of adverse events, heart attack, congestive heart failure, or other problems. Great outcomes you can see with scores at long-term follow-up. What did we find? We published here, you can see, and you can use the QR code at any time to get the article. On lateral unicondylar knee replacements, 61 of them, you can see less than 60 years of age and older than 60 years of age. Survivorship was 100% at 10 years. The older group, 98% at 5 years here, it's 96 at 10 years. And what we do in our studies is we use PASS. PASS is, how does the patient feel they're doing, not how we feel we're doing. They have to answer the question, and that's been now the new score to let you know. And just so you know, at the PASS scores, for a total knee, the average PASS score is unfortunately 67%. For unis, it's in the 80s, just to give you a distinction. Second concern, heavy-set people, longer operating time, high risk of complications. Can I debunk that myth? Well, I can tell you that BMIs over 30, significant trend, is discharged to home, and here you can see the higher risk with the relative risk value if it goes BMI 35, 40, and 50. There's no debate as you get bigger, you do worse with a partial knee replacement. So what can I tell you? Here's our study. It's in submission in one of the journals, 200 fixed bearing cemented, and we broke them up into non-obese, less than 30, 30 to 34, 35 to 39, greater than 40. The bottom line, we have to wait till it's published, is survivorship was there, but I will say you want the BMI less than 35 to be successful. You can go up to 35. I can't give you 15 and 20-year data beyond that. I hope to come back, but that's what we know today. ACL deficiency, everyone said don't do a uni if you have an ACL deficient knee. I can tell you this is other people's articles, and I'll show you ours. The rate of revision is equal for ACL deficient and ACL intact. Probably as you get older, the capsule gets tight, and so you don't have that instability. And here it is, 100% ACL deficient rates in other people's articles. We wrote an article, again, in Journal of Arthroplasty, published, that really the key in ACL deficient and ACL intact knees, there is no difference in the outcome. The key is the tibial slope. And we're here for sports medicine today. If the slope is greater than 7 degrees, you will fail in a uni with an isolated ACL deficient knee. If, on the other hand, you have an ACL present and absent and it's less than 7 degrees, you will do fine, and that's the bottom line of this article. How about varus and valgus, greater than 10 degrees, over and under correcting? I will say to you, we used to think everybody has to be 0. We now know that going to a little varus is really important. And by having it around 1 to 4 degrees, patients do well. So we took a look at the study here of 150 patients and looked at the opposite side and also what they lived at. And this was published in JBJS, and what we saw is if you restore someone to 3 degrees of their arithmetic varus, what they love living at, yes, they may have a small varus thrust. I don't deny that. They're happier patients in then bringing them back to neutral or alignment. And here's kind of the summary that was in JBJS, but basically what it says, I have 18-year survival, 19-year survival, but if you don't do it, they seem to fail at 15 years. And so I encourage you to do a uni, bring it to their normal varus alignment by comparing to the other side. How about high activity level? Mechanical failure, worried about singles tennis, skiing, soccer, or here you can say, well, the point is other people have now said that you can do a partial knee and return them back to the levels even for over 65 and under 65 years of old patients. Here you can see that another article just recently published in the American Journal of Sports Medicine this past June, 169 patients that underwent unis, fixed bearing, non-robotic, and we used the American College of Sports Medicine for vigorous sports. So it's skiing, singles tennis, soccer, as well as moderate sports. What did we find? 98% returned to their sport within 5 months. You tell me a cartilage procedure that you can get, and I'm a cartilage surgeon, that you can get someone back. I'm not saying the 17-year-old, the 23-year-old doesn't need it, but show me someone who's now 34 years of age that goes through 4 cartilage procedures and never returns back to professional soccer. You can use the uni, and now we know we have 20-year follow-up, and we still are going. This is not a procedure that I want you to do that converts to a total knee. This is the procedure for life that I'm advocating. Concerns about lateral patella facet. They said if you have patella facet arthritis, you better not do a unicondylar knee. So other articles now showing no significant difference in survivorship between patients with symptomatic versus asymptomatic lateral facet patella arthritis. What we do? We went back 177 non-robotic medial UKAs looking at medium patella incision, looking at 47 patients symptomatic with lateral patella facet arthritis, 130 controls, 97% survivorship. The conversion to a total knee at any point was equal with the controls versus the lateral patella facet at 18 years out. It is not an absolute contraindication, and I'll show you the algorithm so that you can feel comfortable when picking your patients again. How about mental health? It's a big issue for us in the United States. So this has been submitted to JBJS, you'll see British, but the idea is that people who undergo arthroplasty who have poor preoperative mental health do not do well. In fact, 6 times the satisfaction rates from anxiety and depression. And they have persistent pain, yet you did the best operation, the x-ray looks terrific, and you can't explain it. And they don't get out of the hospital fast enough. So here have been submitted, it's not yet accepted, 163 unis with pre-op and post-operative scores for mental health. We had started with people with low mental health, middle, level, and high. And you can see significant improvement with any arthroplasty procedure that's there. And the low preoperative mental health had the biggest lift when giving them a partial knee replacement. So that mental health yields lower postoperative scores, and you want to optimize your patients before you consider any arthroplasty procedure, if you would. But how do you do this? You have to start with a physical exam. The problem is we have to be physicians first and not be myopic as a knee surgeon. So if patients have low back pain, they may need an epidural steroid that's giving them pain in the knee. I'm sure we all see, as I do, someone that had a total knee, it looks beautiful, and it turns out they missed the fact that an L4, L5 herniated disc. You can't do that. You can't miss it. You can't miss, you know, a skiffy gives you knee pain, but the problem is in the hip. Same idea for the adult. If there's osteoarthritis of the hip, deal with the hip, not with the knee. Make sure the whole patient is ready for the procedure. The physical exam, I ask them, where's your pain? I'll show you. I ask them, is it pain going downstairs? I don't know why, but people with medial compartment varus knee complain of pain worse going downstairs rather than pain going upstairs. People with lateral compartment arthritis do not like going upstairs. They don't say it hurts going downstairs. And the motion has to be correctable. I don't want any anterior-posterior instability. It has to be correctable, as you can see, and I do my varus and valgus stress. So my preoperative workup, make sure you can see that top film, they look normal. The bottom film looks like bone on bone. That's the Rosenberg view. Make sure you get the Rosenberg view, and you'll know that they're bone on bone. That's the PA view at 15 degrees. Not a notch view. You have to aim the beam equal to the joint. So I'm here to say pain on one side, consider the UKA, because as it says, it nearly restores normal function, prevents further disease. This is not a way station to a total knee. It expedites return to work easily. It's isolated single compartment arthritis, angular deformities up to 10 degrees. ACL deficient, it's fine. Ignore patellofemoral arthritis. This article in JBJS really has it. It's a little complex, but I'm going to tell you. Open the patient to your office. Ask them to point where their pain is. If they say it's on the inside of the knee, ask them, do they have pain going up or downstairs? If they say it's going downstairs, if you follow the algorithm, draw a line down the middle of their knee. Don't just rely on the x-ray. Talk to the patient. Evaluate with the x-rays. Follow the guidelines. Understand the BMI. And then pick. It may be a total knee replacement, as it says in the red. No, they have pain everywhere. They put their hand in front of their knee. Guess what? That's a great arthroplasty patient. It's not a partial knee. But if you have them focus and go home, they'll really figure it out. And so I encourage you to follow an algorithm that can really give you the basis, and it's published for you. This is my patient, 2 hours, walking out of the operating room. Okay? We use tricks. We use something, and I'm not a consultant, Exparel, and so the point is there are ways to make them numb in the knee for 3 days, and they only use meloxicam, so that's an anti-inflammatory. There's no narcotics, and they're feeling great. It's outpatient surgery. You can't beat it. I can't thank the professor and our president, because I know I was supposed to speak on Friday. Tomorrow I speak on shoulder. I'll change my hat in the morning. But I thank you for listening today, and I hope I help you in your patients in your office. Thank you very much.